If you've been through an IVF cycle that failed, I want to start by saying something that I completely mean. What you went through was not just a medical procedure that didn't work. It was months of preparation, of hope, of injections, of monitoring appointments, of the physical and emotional weight of an entire process. And then the devastating moment of finding out it didn't work. This is not a small thing, and I don't want to gloss over it. But I also don't want to leave you without answers. Because in my experience, in 24 years of working alongside women and couples after failed IVF cycles, the most common thing I hear is this. My clinic told me the embryo was probably abnormal. They recommended another cycle, but nobody sat down with me and actually explained why it failed. And that gap, that absence of a real explanation, is what I want to address today. Because the embryo being abnormal is sometimes the answer, but it isn't always the answer. And even when chromosomal abnormalities are part of the picture, there are almost always additional factors that affect whether genetically normal embryos implant and sustain. Factors that most clinics never test for. Factors that, when addressed, change the outcome. Today, I'm walking you through the 5 hidden factors behind IVF failure that I see most commonly, and more importantly, what you can do about those right now. I'm Dr. Marc Sklar, the fertility expert. Before we go any further though, I've created a free guide called The Proven 6 Ways to Improve Egg Quality in 90 Days. You can find that link to download it in the description below. The first hidden factor is endometrial receptivity, and this is one of the most under-investigated areas in IVF when transfers keep failing. Here's the issue. Even if your lining looks adequate on an ultrasound, 8 millimeters, trilaminar pattern, progesterone checked, the lining may not be receptive at the time of your transfer. The window of implantation, that narrow time frame during which the endometrium is biologically prepared to receive an embryo, varies from person to person. Standard frozen embryo transfer protocols assume this window opens on a specific day of progesterone supplementation, but research shows that in some women, this window is displaced. It opens earlier or later than the protocol assumes. The ERA test, the endometrial receptivity analysis, is a biopsy test that looks at the gene expression pattern in your endometrial tissue to identify whether you are receptive or non-receptive during a mock transfer cycle. It's not perfect, and it's not necessary for every patient, but for women with 2 or more failed transfers of chromosomally normal embryos, it is a conversation that needs to happen. Related to receptivity is the uterine microbiome. The EMA test looks at the bacterial ecosystem of the endometrium. Research has shown that women whose uterine microbiome is dominant by lactobacillus species have significantly higher implantation rates than those with a more mixed or pathogenic profile. And this can be addressed through targeted probiotics, gut work, and in some cases, specific local treatments. I worked with Kay, a member who had had multiple failed transfers with genetically tested embryos. Everything looked right on paper. When we pushed for an ERA testing, her window was displaced by 24 hours. 1 day's adjustment in the protocol, and her next transfer worked. This is not a minor detail. It can be everything for you. The second hidden factor is immune activation, and this one consistently gets the least attention from conventional reproductive medicine. Here's the issue. Your immune system's job at the moment of implantation is to do something paradoxical. It has to tolerate a semi-foreign entity, the embryo, which has genetic material from both parents, while simultaneously protecting the uterine environment. This is a profoundly complex immune operation. And when it goes wrong, when the immune system is overactivated, or when specific immune pathways treat the embryo as a threat, implantation fails. The most studied immune factor in recurrent implantation failure is natural killer cell activation, or NK cell. Uterine NK cells are normally present and play a role in supporting implantation. But when they are overactivated, when they are essentially too aggressive, they attack the implanting embryo before it can establish. Peripheral NK cell testing from a blood draw gives us a proxy measure for this. Antiphospholipid antibodies, which cause microclotting in the placental circulation, are another immune factor that, when present and unaddressed, results in early pregnancy loss even after apparent implantation. They require specific treatment, typically low-dose aspirin or heparin, to manage it. And then there is the general inflammatory environment. CRP, homocysteine, inflammatory cytokines, when elevated, they disrupt the immune signaling required for successful implantation. What we do in the HOPE program when this pattern is present is start with an anti-inflammatory diet, AIP for autoimmune related patterns, vitamin D optimization to generally therapeutic levels, omega-3 fatty acids in therapeutic doses, gut work to reduce systemic inflammation, and appropriate medical co-management with the clinic around specific interventions. The conversation with the women I worked with who had been through 6 embryo transfers, chemical pregnancies, and normal genetic testing, and whose immune environment had never been evaluated, is one of the most important conversations I have in this field. The investigation was simply never done until we did it. A stimulation protocol to mature follicles and retrieve eggs for fertilization is the biggest factor impacting success in an IVF cycle. Most couples have no idea how to understand if a protocol is the right protocol for them, but the protocol itself, which you are trusting in your IVF doctor to create for you, can make or break an IVF cycle. Most often, your IVF doctor has between 2 and 4 protocols that they like to use, and they are basing which one they pick for you on your hormone levels, your age, height, and weight. Most often, they are looking at your AMH, FSH, and estradiol to determine which protocol they're going to use. But this is not a perfect science, and often your first cycle is an experiment. They all hope it goes well, but it may not go as planned. In those situations, you are often made to feel that your ovaries did not respond the way we hoped, and we need to try something different. This makes you feel like you failed. You did something wrong. You weren't good enough. The reality is that the protocol caused this, not you. If the meds were different, likely your ovaries would have responded and responded better. IVF success is about finding the right doctor for you, with the right protocol for you, with the right clinic to support you along the way. That is different for each one of you watching. Today, I spoke to a HOPE member named P. Unfortunately, her first stimulation cycle failed and she was blaming herself. I explained to her that this was all about the protocol. The protocol didn't support egg quality and was not managed properly along the way. We discussed how this could have been different for her the next time, what to ask for, how to advocate for herself, and maybe even if she needed to find a new clinic. These are real conversations that we have every day because you deserve the right support the first time, not after the 5th failed IVF cycle. The 4th hidden factor is inadequate hormonal preparation. And this is one often comes down to the quality of the monitoring and the protocol leading into the transfer. What I see frequently is progesterone levels that are checked once after the initiation of supplementation and then assumed to be adequate, but progesterone fluctuates, and the level at one blood draw does not tell you whether it was adequate throughout the luteal phase support window. Many clinics do a single progesterone check, see a number above the threshold, and consider it addressed, but the level may have been dropping, or it may have been adequate at noon when the blood was drawn and insufficient at other times. I also see estrogen that was not monitored closely enough in the lining building phase of a frozen embryo transfer. Lining that looked thin but wasn't formally addressed before the transfer proceeded. Thyroid function that wasn't optimized, specifically free T3 that was in the low normal range when it needed to be in the mid to upper for implantation support. And I see women who went into transfers when their bodies were under significant amounts of stress, still grieving the last failure, still in fight or flight mode, cortisol elevated, without any specific support for the nervous system and HPA axis around the transfer. What the HOPE program approach to transfer preparation looks like is that we build a pre-transfer protocol that addresses the hormonal environment specifically: thyroid optimization, progesterone support beyond what the clinic monitors, HPA axis stabilization, and nutritional status. The 90-day window before retrieval and the 60-day window before a transfer are treated as preparation phases, not waiting periods. And the fifth factor, the one that is the hardest to quantify but the most consistently present, is chronic stress, dysregulation, and dysregulating the implantation window. I want to be precise here because this is not about telling you to relax and it will work. That is not helpful, and it's not what I meant. What I mean is this: the implantation window is a hormonally governed event. The endometrium becomes receptive and then becomes non-receptive based on precise hormonal cascades. And the HPA axis, the stress response system, interferes with this cascade in measurable ways. Specifically, chronically elevated cortisol around the time of transfer suppresses the progesterone receptor activity in the endometrium. Even if progesterone levels are technically adequate, the endometrium's ability to respond to that progesterone is diminished when cortisol is high. This is sometimes called progesterone resistance, and it is a real documented physiological phenomenon. Beyond the progesterone receptor effect, high cortisol at the time of transfer also affects uterine blood flow through its effect on vascular smooth muscle. And it modulates the immune environment in the uterus in ways that can shift it from receptive to reactive. So the work of nervous system regulation, breath work, movement, acupuncture, sleep optimization, reducing anticipatory anxiety is not optional, nice to have support around a transfer. It is a physiological intervention that affects the biological environment of implantation. It's necessary. And the support of being inside a community that understands what you're going through, the live group clinics, the private member community, the direct access to guidance is part of what creates that physiological safety, because you are not doing this alone and your body knows the difference. If you've been through a failed IVF cycle or multiple, and you haven't had a conversation that addressed even one of the 5 factors I just walked you through, I want to invite you to have that conversation with my team. A fertility assessment discovery call is where we look at your IVF history, your labs, and your full clinical picture, and help you understand what wasn't addressed and what to do next. The link for that is in the description below. If your IVF cycle failed, I want you to hear this. The failure of the cycle is not the failure of your body. It's information. It's telling you that something in the picture needs to be different, and that something is almost always findable and almost always addressable, fixable. I've worked with women who had 4, 5, 6 failed transfers and went on to have successful pregnancies after we identified and addressed the missing pieces. The woman who had 6 embryo transfers and finally found her answer when we investigated her immune environment. The couple just did not have the right protocol to support their egg quality. The woman whose window of implantation was off by 24 hours and whose ERA result changed the entire protocol. These are not rare cases. These are the cases I see every day, and they are waiting for someone to look more carefully. And apply for a fertility assessment discovery call if you're ready to stop cycling without answers and start moving with real information. And for your next video, I've done one on the preparation you should be doing before your IVF retrieval, the 90-day window that most clinics never address. If today's video opened a door for you, that one will walk you right through it. Watch it next. And until the next video, stay fertile and stay hopeful.